Acute coronary syndrome, Part 3. Acute coronary syndrome, early risk stratification. Approximately 12% of patients will die within 1 month and 20% will die within 6 months of the index event. The risk markers that are indicative of an adverse prognosis include recurrent ischemia, extensive ECG changes at rest or during pain, the release of biochemical markers, namely creatine kinase or troponin, arrhythmias, recurrent ischemia, hemodynamic complications like hypotension, mitral regurgitation during episodes of ischemia. Based on a global registry of over 100,000 patients, the GRACE registry or the GRACE score, GRACE stands for the Global Registry of Acute Coronary Events. The GRACE score estimates in-hospital, 6-month, 1-year, and 3-year mortality risk after a heart attack. Many variables are entered into the GRACE risk score, including the Killip class, which is the degree of pulmonary congestion following an acute coronary syndrome, systolic blood pressure, heart rate, age, serum creatinine level, other risk factors like cardiac arrest at admission, the degree of ST segment elevation, and the degree of elevation of cardiac enzymes. The higher the risk score, the higher the possibility of in-hospital death, with in-hospital death reaching as high as 52% in patients with a GRACE risk score of around 250. Early risk stratification has implications on subsequent management of patients with acute coronary syndromes. This slide and the next slide are crucial in your understanding of how we manage a patient with an acute coronary syndrome. Managing patients with acute coronary syndrome starts with immediate clinical assessment, electrocardiography, and troponin assessment. Shall we confirm the diagnosis? The patient is immediately transferred to a specialist cardiology unit, placed under cardiac rhythm monitoring, given oxygen therapy, aspirin in a dose of 300 milligrams orally, another antiplatelet named ticagrelor in a dose of 180 milligrams, and a beta blocker, namely metoprolol, in a dose of 5 to 15 milligrams intravenously or 50 to 100 milligrams orally. Then we proceed to defining whether this acute coronary syndrome is associated with ST segment elevation or not associated with ST segment elevation. If it's associated with ST segment elevation, it's called an ST segment elevation acute coronary syndrome, or ST-EMI, or ST segment elevation myocardial infarction. Then we proceed to defining whether the patient has had the symptoms for less than or more than 12 hours. If the patient has had the symptoms for less than 12 hours, then reperfusion therapy is the treatment of choice. And reperfusion therapy means reinstating blood flow in the infarct-related artery. Now we proceed on to defining whether primary PCI, which is opening the infarct-related artery using mechanical means by the catheter, is available within 120 minutes of presentation. If primary PCI is available within 120 minutes of presentation, meaning that you can activate the cath lab and have the artery open within 120 minutes, then this is the preferred management strategy. What if primary PCI is not available within 120 minutes? Then I proceed to defining whether the patient is eligible for thrombolysis or not eligible for thrombolysis. If the patient is not eligible for thrombolysis, then I move on to deciding that the patient needs a primary PCI even if it's not available within 120 minutes. What if the primary PCI is not available at all and the patient is not eligible for thrombolysis? In such case, I give the patient a pentasaccharide named fondaparinux or a low molecular weight heparin subcutaneously. I consider nitrates by IV infusion. What if the patient is presenting more than 12 hours from the symptom onset? Then I use the same strategy, which is giving fondaparinux and low molecular weight heparin. Patients who are eligible for primary PCI are given glycoprotein 2B3A receptor antagonists and are rushed to the cath lab as soon as the cath lab is activated. Patients who are eligible for thrombolysis are given intravenous thrombolytics followed by fondaparinux or low molecular weight heparin intravenously. If the Grace risk score defines that the patient who does not have ST segment elevation or has a non-ST segment elevation acute coronary syndrome has a medium to high risk as defined by the Grace risk score, I proceed to an early in-hospital coronary angiography and consider giving the patient 2B3A antagonist IV infusion. Maintain hospital medications, aspirin, ticagrelor, fondaparinux, low molecular weight heparin, statin, beta blockers, and ACE inhibitor therapy. In case of failure of reperfusion using thrombolysis, then I proceed to giving the patient 2B3 receptor antagonist and proceeding to immersion PCI. Patients should be admitted urgently to the hospital because there is a significant risk of death or recurrent myocardial ischemia during the early unstable phase. Appropriate medical therapy can reduce the incidence of death or recurrent myocardial ischemia by at least 60%. Patients are usually managed in a dedicated cardiac unit where the necessary expertise, monitoring, and resuscitation facilities can be concentrated. Immediate management the first 12 hours. Number 1. Analgesia. Adequate analgesia is essential, not only to relieve distress but also to lower the adrenergic drive and thereby reduce vascular resistance, blood pressure, infarct size, and susceptibility to ventricular arrhythmias. Intravenous opiates, initially morphine sulfate or diamorphine, and antiemetics, initially metoclopramide, should be administered and titrated by giving repeated small aliquots until the patient is comfortable. Number 2, antithrombotic therapy, which is divided into antiplatelet therapy and anticoagulant therapy. Antiplatelet therapy is crucial in patients with acute coronary syndrome. Oral administration of 75 to 325 milligrams of aspirin daily improves survival with a 25% relative risk reduction in mortality. The first tablet, 300 milligrams, should be given orally within the first 12 hours. Therapy should be continued indefinitely if there are no side effects. In combination with aspirin, the early within 12 hours use of clopidogrel in a dose of 600 milligrams followed by 150 milligrams daily for 1 week and 75 milligrams daily thereafter confers a further reduction in ischemic events. In patients with an acute coronary syndrome with or without ST segment elevation, ticagrelor in a dose of 180 milligrams followed by 90 milligrams twice daily is more effective than clopidogrel in reducing vascular death, myocardial infarction, stroke, and all-cause death without affecting overall major bleeding risk. Glycoprotein 2B3A receptor antagonists such as tirofiban and apiximab block the final common pathway of platelet aggregation and are potent inhibitors of platelet-rich thrombus formation. They are of particular benefit in patients with acute coronary syndromes who undergo percutaneous coronary intervention, in those with recurrent ischemia, and in those who are at particularly high risk, such as patients with diabetes mellitus or an elevated troponin concentration. In patients with acute coronary syndromes, antiplatelet treatment with IV glycoprotein 2B3A inhibitors reduces the combined endpoint of death or myocardial infarction. Most benefit is seen in the context of percutaneous coronary intervention, and there is no convincing evidence of benefit in patients who are treated medically without revascularization. Anticoagulation reduces the risk of thromboembolic complications and prevents reinfarction in the absence of reperfusion therapy or after successful thrombolysis. Aspirin plus low molecular weight heparin is more effective than aspirin alone in reducing the combined endpoint of death, myocardial infarction, refractory angina, and urgent need for revascularization. In comparison to low molecular weight heparin, the pentasaccharide fondaparinux in a dose of 2.5 milligrams subcutaneously is associated with lower bleeding rates and better overall survival. Anticoagulation should be continued for 8 days or until discharge from hospital or coronary revascularization. A period of treatment with warfarin should be considered if there is persistent atrial fibrillation or evidence of extensive anterior infarction, or if the echocardiogram shows mobile mural thrombus, because these patients are at an increased risk of systemic thromboembolism.